grateful to Ryan and Sasha for making the time for us this morning. So Ryan Hodges is Program Director for the Women's and Newborn Program and Director of Maternity Services at Monash Health, Victoria's largest healthcare and maternity provider. Ryan practices as a maternal fetal medicine subspecialist and is a member of the Monash Health Executive and Clinical Council for Hospital Quality and Safety and Patient Experience. Ryan is a professor in obstetrics and gynecology with Monash University and clinical associate with the Ritchie Centre, Hudson Institute for Medical Research. And with Ryan, we have Sasha Skinner, and Sasha is an obstetrics and gynecology senior registrar at Monash Health. She's completed a Bachelor of Medical Science in Maternal Fetal Medicine and is a current PhD candidate with an academic interest in translational research. So thank you very much, Sasha and Ryan, and I'll hand over to you both.
Thanks, Belle. Thanks very much for the introduction, and good morning, everyone. Thank you for the opportunity to meet you all and present the work we've been doing now at Monash for the last few years. I became involved in Operative Vaginal Birth Safety Bundle several years ago after a raft of unfortunate outcomes that occurred across Victoria. I did some work with Safer Care Victoria at that time. And then sadly, we also had a very serious sentinel event at one of our Monash Health sites. And what was quite striking to me is that the themes that occurred in rural regional Victoria were the same themes that were occurring in metropolitan Melbourne and were the same themes that were even occurring in our own service. And it was quite striking and really showed to me the importance for and a need for change. We were having obstetricians who were task focused and not having an awareness of what was actually happening in the room. And in the room, there was a lack of a safety culture. And we didn't have a team who was working as one in order to provide the very best outcomes for mothers and babies. And so we came up with a plan, and I looked to Sasha Skinner, who was doing her PhD just commencing her PhD in this program of work, along with Peter Neal and Nadine Murray, one of our midwives. And we put together a multidisciplinary team where we've come up with this Operative Vaginal Birth Safety Bundle. You're going to hear from Sasha in a second around the specifics of the bundle and some of the quite extraordinary results we've been able to achieve at Monash. But in your mind, as you're hearing the details of this, what this has achieved at Monash has been the emergence of a safety culture. And that safety culture is now spreading not only through our maternity services, but also throughout Monash Health, thanks to this work. So just a shout out to VMIA for their support in producing this work and bringing it to all of our Monash Health consumers. And we're very keen to see whether other maternity services in Victoria would also like to participate in this, because I think it's something that's been quite striking and a major improvement for women and babies who we care for. So Sasha, I'll let you go through the details and then we'll be delighted to answer questions at the end.
Thank you, and thank you everyone for having us to talk about this work. I'm just going to give a bit of a background of where we started from and the journey we've been on to develop this bundle and some of the outcomes we've seen and where we're hoping to go from here. So brief background, but operative vaginal birth, as I'm sure everyone in the audience is aware, is where we assist with vaginal delivery with the use of instruments such as forceps or vacuum in the second stage of labour. And we perform it for either fetal or maternal indications. It accounts for 16% of all births in Victoria and up to 1 in 3 births for first-time mothers. So relatively common mode of birth that we see in Victoria. And it is an alternative to the fully dilated caesarean section, which can be a more challenging caesarean section with the fetal head more deeply impacted in the maternal pelvis. We know that both operative vaginal birth and fully dilated caesarean sections can be associated with increased risks for the mother and the baby, in particular for fully dilated caesarean sections, because that fetal head is so deeply impacted. It can be quite difficult to extract the baby. That can lead to neonatal injury, but can also have significant implications for the mother for her recovery, but also future pregnancies in terms of risk of preterm birth and future family planning. On the flip side, we also know that operative vaginal birth can have significant risks for maternal pelvic floor and anal sphincter injury. And there can be increased risk as well for neonatal injury specifically, as well if instruments are either malplaced or there's excessive traction or need to convert to between different instruments or convert from an operative vaginal birth to fully dilated cesarean section. So as Ryan mentioned, where this work really began was when we saw a series of really poor outcomes from operative vaginal birth that were occurring around the state and including a sentinel event at Monash. And as he mentioned, there were a series of themes that were very common between these cases and kept recurring. So one of those themes was inaccurate diagnosis of fetal position. So what we're seeing pop up again and again was situations where we thought babies were in a certain position and they're actually in a malposition or a different position, which led to an unexpected difficult delivery or led to misplacement of instruments and significant neonatal trauma. We saw a significant breakdown in communication between the team present at the operative vaginal birth, and specifically a breakdown in communication between the person performing the birth and the other people that were present for the birth, meaning that they were less able to optimally support the accoucheur if things started going not to plan. There were delays in escalation, specifically delays in involving senior staff, but also delays in converting to a timely cesarean section when an operative vaginal birth wasn't going to plan. And that was really tied in with the other theme of seeing practices outside safety guidelines, where we're seeing excessive attempts or excessive numbers of pulls with instruments or reapplication of instruments after multiple cut pop-offs that led to neonatal injury. And so we put together a task force at Monash Health that was a big task force that involved lots of different multidisciplinary team members, including obstetrics, midwifery, paediatrics, anaesthetics, our consumer representatives, and supported by VMIA to try to address some of these concerns and come up with a safety bundle to improve safety for our mothers and babies. So these are just the components of the safety bundle that I want to walk you through. But the first component was assessing fetal position with the adjunct of intrapartum ultrasound. We looked into this because there's lots of excellent evidence out there that we can improve our accuracy of assessing fetal position by using an adjunct of intrapartum ultrasound in addition to clinical examination with vaginal examination. And studies have shown that that can drastically improve our accuracy of assessing fetal position. And the studies demonstrated that with vaginal examination, we can get error rates up to 20 or 40%. But with the addition of ultrasound, we can reduce that to less than 1%. So we implemented routine bedside transabdominal ultrasound, looking for simple markers such as the fetal spine and orbits to confirm our vaginal examination findings of position prior to performing an operative vaginal birth. The next component was trying to address how the team functioned and the escalation pathways during an operative vaginal birth. And so ultimately we decided on a timeout and procedural safety checklist. That was also with the backing of a lot of evidence, particularly from fields in aviation and military, about the effectiveness of checklists when developed correctly and how they can improve multidisciplinary communication and adherence to guidelines. But we really wanted to ensure that this form was able to really engage the team and importantly engage the woman. So our first part of this form is the timeout procedure, which is the idea is that there's a pause before the operative vaginal birth where you engage the woman and the woman leads this conversation of having a timeout of what the situation is in front of us, what we're planning to do, what are potential risks we need to prepare for, and having that transparency about what we're planning and what the clinical assessment is. What we really hope to do in this timeout is make a plan from the beginning of when our triggers would be to convert to cesarean section, so that later, if those triggers then come up, we're more empowered to be able to escalate to do that. We then have the second side of the form, which is the procedural checklist part, which is performed during the procedure. And the goal of this side of the form is to check in with each contraction to ensure we're still happy going along the plan that we had made. The idea is to maintain communication and maintain situational awareness amongst the team. And it has some triggers for when we need to consider reassessing, changing instruments, or converting to cesarean section. These forms have undergone lots and lots of iterations and have had lots of staff feedback to try to make them as user-friendly and incorporate them into our birth suites appropriately. And then finally, the birth experience and postnatal debriefing pathway. We recognised that if we were making a safety bundle for operative vaginal birth, we really wanted to include women in how we were developing this and ensure we were considering not only their physical safety, but also their psychological safety. We know that any operative delivery can increase a risk of negative birth experience, and we wanted to make sure we were really considering that in how we developed this bundle. So after a lot of searching, I ultimately chose this validated birth experience questionnaire, which we implemented routinely for all women having an operative vaginal birth, with added extra sections to be able to get more additional feedback about how their experience of that birth was. And we developed a postnatal debriefing service as well. So a small number of our senior midwives led this postnatal debriefing service for anyone that had been flagged as having a poor experience, or anyone that self-referred themselves into this debriefing service. We had a really great uptake and response to this service. So we actually expanded this service out to all births at Monash Health at the start of this year. So this is now offered to all women birthing at Monash Health, whether they have an operative vaginal birth or otherwise. A little bit of a timeline of events. This is when we had our Sentinel event at Monash Health. We then created the task force soon after that. It took over a year to develop something to pilot for the safety bundle. And then we went through a period of seeking lots of feedback from staff, implementing it, see how it actually worked on the floor, and then finally formally implementing it in August 2022. So this is the uptake that we've seen of the safety bundle over the last 2 years of the timeout checklist and ultrasound. So we've had a massive change in practice at Monash with the use of these things. So now our timeout and checklist is used in over 90% of operative vaginal births at Monash. And ultrasound, if we looked at prior to the pilot period, we used intrapartum ultrasound less than 5% of the time before our pilot period. But then after implementation, we're now up to nearly 80% of births using the ultrasound. And then our birth experience survey and postnatal debrief pathway, which took a little bit of time to set up. So we implemented that in July 2023 for all women having an operative vaginal birth. But then from December 2023 onwards, it's now been expanded to all births, as I mentioned before. So I'd like to share with you some of the outcomes that we've had from implementing this service. So the post-bundle period is that graph I've just shown you, and we're comparing the outcomes in that period to the pre-bundle period, which was prior to piloting the first versions of the safety bundle. So through that time, we've seen a 20% increase in consultant presence at our operative vaginal births. We've seen a 31% reduction in births where we've had more than 3 pulls or more than 2 cut pop-offs with a vacuum device. And we've seen a 76% reduction in incomplete documentation where we haven't documented things like the fetal position or station or other clinical assessment. In terms of our delivery outcomes, we've had no change in the rates overall of forceps, vacuum or fully dilated caesarean section. We still have the same distribution of modes of birth at our institution, but we have seen a significant reduction in need for sequential instruments, in particular where we've need to convert from vacuum to forceps. And we've seen almost a 30% reduction in the need for caesarean section for an unsuccessful operative vaginal birth. And while small numbers, we've seen quite a large reduction in our unsuccessful operative vaginal births that are performed on birth suite that then need transfer to the operating theatre. In terms of our baby outcomes, we've had an 81% reduction in babies born in an unexpected position at birth. This is an important outcome because when we looked at these babies, even though there's a small percentage of them born in an unexpected position, those babies that are born in an unexpected position have a much, much higher rate of that operative vaginal birth being unsuccessful, a much higher rate of needing a caesarean section for an unsuccessful operative vaginal birth, or more than double the rate of anal sphincter injury for the mother, a much higher rate for needing resuscitation, more than triple the rate of low APGARs, significant neonatal birth trauma, and double the rate of special care nursery admissions. Overall, between the 2 time periods, we've seen a 24% reduction in neonatal morbidity, And this is a composite of low APGARs, significant neonatal birth trauma, NICU admission, cardiac compressions, intubation, or therapeutic hypothermia. But most of that has been driven by a significant reduction in neonatal birth trauma, such as subgaleal hemorrhage, lacerations, fractures, or large cephalomatomas, and a 31% reduction in NICU admissions for these babies. In terms of our postnatal debrief pathway, we've had over 800 responses to the birth experience survey and performed nearly 100 debriefs at our Clayton site. We've also been performing this at the other sites, but that's what we've got the numbers for. And we've had really wonderful responses from this. So these are women that have come through their birth and recognise their birth as being a traumatic experience, and then having the opportunity to go through this pathway. They're telling us things like they feel like they've emotionally and mentally been able to heal from this, from being able to process their birth. They were able to get the answers and closures that they needed to feel safe and navigate some of the challenging emotions that they were experiencing in the postnatal period, and that this service was really able to empower them to face future births. So that was really encouraging to see. We've been very active in seeking staff feedback throughout this process. We were very aware that we're implementing things like a checklist and change in practice. It's really important to make sure that our staff, it was something that was going to be useful for our staff and something that our staff were very involved in the process. So throughout this period, we've been seeking feedback and making refinements to the bundle as needed. But from our staff, we've learned 92% of our staff felt that this bundle improved communication between healthcare staff. Nearly 80% felt that it improved communication with the patient. 85% felt that it improved accuracy of assessing fetal head position. 73% felt it improved patient experience, and over 90% felt that it improved patient safety overall. I just wanted to share a couple of quotes before I finish from the staff feedback, because in addition to the surveys, we've also been performing interviews to really try to get down to the nitty-gritty of what it is that has been changing in our birth suites. And one of the themes that comes up that Ryan mentioned was this concept of safety culture. So I just wanted to share a couple of quotes demonstrating that from some of our interviews.
There are certainly elements of the actual bundle themselves, you know, the tool, the ultrasound, the education, all of those little things. But I think actually underlying all of it, what you have created is a template for how clinicians can work together to create much more women-centred and women-focused care.
No, I love it. I think it's good. For me as in charge, I want anything that's going to make my job as being in charge feel not easy, but just less stress and, you know, and organised. And as you know, in a birth suite, it can't always feel that way. But if it can feel like that majority of the time, it just makes everyone's life a lot easier and people want to come to work then.
And I think that's got a lot to do with the implementation of the bundle and the message that it sends that actually that's not safe and that's not standard evidence-based practice and that we need to be improving.
So we've done a lot of thematic analysis over the feedback we've been receiving from staff, and just to understand a bit about what's been working to help develop this safety culture and what we need to be adapting. And so these are some of the themes that we've found come through that's been contributing to that development of safety culture. It quite nicely fitted into the acronym of CALMA, which was fitting because the word calm came up quite a lot in those interviews and feedback in that concept of feeling calm in the birth suite environment. But the first theme that came through was this concept of having that clarity and structure so that everyone knows what's next. Everyone can work as a team, and that can just eliminate some of the panic. Agency and empowerment was another big theme, to feel like anyone in the room could feel pretty confident that they knew how to keep the mother and the baby safe and how they could check off all the major steps. This concept of learning and adaptability was more in the process of how we went about implementing the bundle and the importance of being flexible and getting feedback from staff and adapting it to what it's needed. Monash Health has a number of sites. We have 4 maternity sites. And so we've had to slightly adapt this at each of our sites to ensure that it fits the needs for that local setting. Mutual respect was crucial, and it doesn't work unless you are able to develop that culture of having mutual respect between different staff members in the room, and be able to use it as a tool to make sure we're always coming across as a joint project and having that respect. Using it as a tool for escalation was a key point in how we can use this. So having that non-threatening capacity to escalate despite hierarchy. And resourcing. So having the accessibility of the form there so that it's easy to know what's next and what is recommended in the guidelines that's accessible and present, but also things like having availability of intrapartum ultrasound that's useful and ready to use. So final lot of quotes I'd like to share, which also came out of our interview, was the concept of expansion and spread. So organically, what came out from our staff is this concept of wanting to see some of this culture change spread to other areas of maternity care.
I would love to see elements of this spread into other aspects of maternity care.
I feel like if we could have a clear-cut form that flows as beautifully as that in every emergency situation.
I think it should just be a standard of practice.
So that's a bit of a run over of the bundle that we've developed at Monash Health and the different components that we've put into it and some of the research we've done alongside to really understand what's working and what's not throughout that process. We were really excited to be winners of the Victorian Public Healthcare Awards and see this work being recognised in that light. So that was very exciting. And the next step in moving forward was trying to gauge interest about whether or not this would be a useful thing spreading across other maternity centres. We know we've already implemented it at the Women's Hospital and they've had great uptake of adapting and implementing it in that setting. And so now we're looking forward to see if it would be something that would be useful at other centres.